Dahlman. Good evening. I'm Deborah Dahlman, and I'd like to say welcome. We want to thank our host tonight, Senior and Disability Action of San Francisco. We will be recording this meeting, and the meeting will be sent to all who have signed up or request a copy. The title of tonight's teach-in, Medicaid Under Fire. What is Medicaid and how do cuts affect everyone? Our format tonight, I will introduce Anna. She will then present to us, and when she's finished, we'll open up for questions. If you could mute yourself until the end when we open up for questions, would really appreciate that. In late 2022, I met Dr. Malinow. Her leadership, patience, and presence have moved me to engage more deeply on a number of different topics. Dr. Malinow, or Anna as she prefers, was past president of PNHP, is currently leading the movement to stop the privatization of Medicare. She's a retired clinical professor of pediatrics at UCSF, and she is also on the National Single Payer Steering Committee. Anna, thank you for taking us through this important topic this evening. I'll turn this over to you.
Well, thank you, Deborah, for that wonderful introduction. And I'd like to thank SDA for University for hosting us again, specifically and particularly Ligia Montano and Grace Clark. And I'm going to be sharing my slides and a couple of things that I need to talk about first, and that is that I do have a pretty bad cough, although I did just take some honey. It's worked much better than my albuterol inhaler so far. So thank you for that. And also that I'm going to be talking for about 40 minutes, which is a long time. But Medicaid is not easy. So I will try to get through this as painlessly as possible. But thank you everyone for being here tonight from coast to coast, literally, to hear about Medicaid under fire. A cut to one is a cut to everyone. Now, if you all remember, this is the fourth of our Medicare, our health, trying to make changes to my screen, see if this is going to help or not. Okay, so this is the fourth of our teach-ins with SDA. And if you remember back to our very first teach-in, it was called This Is Not Normal. And it was teach-in about the US healthcare system. And in it, the way that I described a US healthcare system was like a pie. Remember that about half of us have employer-sponsored health insurance. Those are people in the blue part of the pie. About 24 million individuals have insurance through the exchanges, and we did a deep dive into the exchanges during our second teach-in. About 83 million individuals have Medicaid. About 60 million are on Medicare. 9 million people have the best socialized healthcare system in the United States, and that is through the Veterans Health Administration. And that leaves about 10 million individuals who are uninsured. Now, this pie is not static. Most of us spend our entire lives sliding from slice to slice until we finally land on Medicare when we're 65. So today we're going to be doing a deep dive into this piece of the pie, the yellow piece of the pie, the Medicaid piece of the pie, where 83 million Americans get their health coverage. Now, we're going to be talking about the 5 events that changed Medicaid. Its birth, the ACA, COVID, post-COVID, and then HR 1, also known as the Big Beautiful Bill. Now, to think about the birth of Medicare and Medicaid, I like to think of it sort of like a twin birth, because in 1965, both Medicare and Medicaid were born. A lot of people during that time thought of it as a 3-layer cake. Why? Well, because the lower level would be Part A, and that would be compulsory, so that when you turned 65, you automatically got onto Part A Medicare. Part A Medicare would cover 100% of your hospital insurance. It was under Social Security, which was very beloved, and it had uniform national standards for eligibility and benefits. Very, very important that there were uniform national standards. On top of Part A, we had Part B, which was the next layer of the cake. This, instead of being mandatory, was voluntary, and you signed up for it when you turned 65, and it would cover outpatient bills, such as your doctor's bills, not hospitals, but outpatient bills. And it would be funded through government subsidies, plus premiums that the beneficiaries themselves would pay every month. And on top of A, B, and C came Medicaid. Medicaid was optional state-run insurance to cover the medical care for the poor. So while A and B covered those 65 and older, Medicaid would cover the medical care for the poor. It would be means tested. We're going to talk about what that means. And it gave states huge authority to decide eligibility and benefits. So it's not the federal government making these federal regulations. It would be up to the state to decide eligibility and benefits. So in 1965, Medicare and Medicaid were born. Now, two things that I want you to take away with today, and that is that Medicaid is administered by the state. That means that there are 50 different ways of administering Medicaid in this country, and it is funded through the federal government and the state government. Now let's talk about funding Medicaid, because this is very, very, very important. And is obviously the reason why we're here and why it is that Medicaid is under fire. The way that Medicaid is funded is through this formula called the Federal Medical Assistant Percent, also known as FMAP. And I'm going to be calling it FMAP because it's much shorter. Now, this formula is created for every state. It's very different, and it is based on the per capita income of that state. So you have poor states, and then you have richer states. The federal government decided that they would be more generous to the poor states and less generous to the rich states, but always give at least 50% to every state. What does this mean? Well, let's take an example. The poorest state is Mississippi. And let's think about $100 worth of health care for a beneficiary on Medicaid. For that $100 worth of health care, the state of Mississippi only pays $23, and then the federal government matches it with $77. So for the state of Mississippi, it's an amazing deal that they get $100 worth of health care for their people on Medicaid for only $23. Now, richer states, California happens to be one of them, but there are like 6 or 7 that are considered rich. Massachusetts, it's one. New York is another one. At any rate, there are 6 or 7 of them. As I said, the federal government would give at least 50%, and that's exactly what the state of California gets. It gets for every $100 worth of health care, they pay $50, but the federal government pays another $50. So while it's not as good a deal as living in Mississippi, it is still a great deal that they only have to pay for 50% of the healthcare costs for the people on Medicaid. So the reason why we're taking a little bit of time to talk about this is because this is going to come up again and again and again and again. Now, who qualifies? Well, as I said, it depends on the state. However, it is based on the federal poverty level. And 100% of the federal poverty level for a family of 4 in 2025 is $40,187.50. The reason why I'm putting in the 50 cents is because, as you will see, it does become important, whether you're a little bit above it or a little bit below it. For an individual, it's $15,650 per year. Now, that's the federal poverty level. Let's talk about who qualifies for Medicaid in California. Now, Every state is different. I want you to understand that I'm just going to be talking about California, even though we do have people from Texas, and we are going to be talking about Texas in a minute. But we do have people from Massachusetts as well. So, right now we're going to be focusing on California. How do you qualify for Medicaid in California? Well, it depends on several factors, not only on your income based on the federal poverty level, but also if you're a child, if you are pregnant, if you're an adult on SSI, or if you're over 65 years of age for Medicaid to pay for your long-term care, because it's not Medicare that's paying for nursing homes, it is Medicaid. So let's take a look at a child in the state of California. If the family makes up to 208% of the federal poverty level or less, then that child will qualify between 0 and 1 years of age, will qualify to be on Medicaid. Now let's take a minute to talk about CHIP. That's the Children's Health Insurance Plan that was passed into law in 1997 to do what? Well, it was to cover the healthcare needs of children whose parents made too much for Medicaid, but not enough to pay for private health insurance. Remember, 1997, there were no exchanges, no enhanced subsidies, no subsidies at all. So for this reason, CHIP was created to help out those parents who made a little bit too much for Medicaid, to get Medicaid. So in California, it covers families with children 0 to 1 up to 266% of the federal poverty level. Now, the day your child turns 1, that family can only make up to 142% of the federal poverty level and have the child qualify for Medicaid. CHIP stays the same. The day your child turns 6 to 18, that family can only make up to 133% of the federal poverty level and have that child still qualify for Medicaid, and CHIP stays the same. Now, I hope you're still with me. It is complicated, particularly if you have 3 children and your income is somewhere around here, where your 9-month-old qualifies, the 2-year-old doesn't, and then the 7-year-old doesn't either. So it does get complicated within the same families. And CHIP is not the same as Medicaid. CHIP does have monthly premiums that Medicaid does not have. If you are pregnant in the state of California and you make up to 213% of the federal poverty level, Medicaid will cover your prenatal care as well as your delivery and your postpartum care. I say here 60 days. The ACA, COVID changed that, and we're going to get to that in just a second. And then CHIP is even more generous because it goes up to 322% of the federal poverty level. If you're an adult in California and you make up to 138% of the federal poverty level, then you will qualify for Medicaid if you make under it. If you make above it, then of course, or if you make $2 more that month, then you no longer qualify for Medicaid. And this is something that used to happen all the time, called churning, is that people would make a couple more dollars a month and then boom, they would lose Medicaid, fall off the rolls, known as churning, and have to wait until another month when they would be eligible again. If you are disabled on SSI, then you can make up to 138% of the federal poverty level and qualify for Medicaid. And long-term care, so nursing homes for people over 65 in California, is not income-based. In fact, beneficiaries are required to contribute nearly all of their income, and that would include any wages, any Social Security income, any pensions, any IRAs, or any other source of income, to the cost of care, meaning to Medicaid. However, they are allowed to keep $35 per month for personal needs allowance so that they can buy their grandchild a present for $35 every month. So this is Medicaid and CHIP in California. And as I said, it is different in every single state. Now, how did the Affordable Care Act change Medicaid? Well, in 2010, the Affordable Care Act was signed into law. Obviously, it had to go through the courts, the Supreme Court. So it wasn't until 2014 that Medicaid really saw the big changes from the Affordable Care Act. What it did is it wanted to remember The way that the ACA decided that they were going to shrink the number of uninsured, that purple piece of the pie, through simple geometry, is that they are going to just increase the sizes of all the other pieces of the pie. So they made an employer mandate, boom, that made the blue piece bigger. They created the exchanges, boom, that made the orange piece bigger. And they expanded Medicaid. So they made that yellow slice bigger. And by definition, through simple geography, that slice of the uninsured, that purple slice, became smaller. So the way that the federal government decided that they were going to expand Medicaid is to tell the states, okay, this FMAP, remember that's the federal medical assistance percentage that we used to give you, a lot for Mississippi and and still 50% for the richer states and then all the other states in between. What we're going to do is for anybody who is newly eligible into your program, we're going to pay 100% of their medical costs for 3 years and then 90% in perpetuity. So it was an amazing deal to have the federal government say, we're going to give free health care to all of these new eligible individuals in your state. So how did they do that? Well, as a result, they added all of these adults, parents and not parents, who made up to 138% of the federal poverty level, because that's what the ACA said. You can add all these people as long as they're under 138% of the federal poverty level. Above that, then they'd be able to get the subsidies to buy into the exchanges. Now, as a result of adding all of these adults, we also added many millions of children of these new adults into Medicare and then CHIP, which became known as the welcome mat. I do not want to understate the importance of the expansion of Medicaid under the Affordable Care Act, because for the first time in many people's lifetime, it allowed them to have medical care. It allowed them to see a PCP. It allowed them to take care of their chronic conditions, of their diabetes, of their high blood pressure. In states, when you compare expansion states versus non-expansion states, states who expanded have better life expectancy, better chronic disease outcomes. And there are all these ripple effects. Not only is the state government better and their incomes are better, but also even high school graduations are better as a result of expanding Medicaid. So I do not want to underplay the importance of the expansion of Medicaid through the Affordable Care Act on the lives of millions and millions and millions of Americans. So we have to say that. Now, not every state obviously expanded Medicaid. About 27 of them adopted it pretty quickly in 2014 after it went through the Supreme Court. And then the rest of the states, the rest of the 41 states, slowly started to expand, either through their legislatures, through their governors, or through referendums where people voted. 9 states are still holdouts. 9 states still refuse to expand Medicaid. So then came COVID, and that changed Medicaid again. 2 laws were very important during COVID that made significant impacts to Medicaid. The Families First Coronavirus Act, which was signed into law by President Trump during his first administration, introduced something called continuous enrollment. So we kind of talked about enrollment before because you had to either re-enroll every 6 months or every 12 months, depending on the state. But what the government decided to do during a pandemic, they thought, wow, it's probably not a good idea for people to lose their Medicaid in the middle of a pandemic. So why don't we just get rid of enrollment altogether and just continuously enroll people through the public health emergency so they do not need to worry about that. So we're not going to get that churning, 10% people losing their Medicaid. Now, as a result, because this would cost states a little more, the federal government gave them a carrot and said, okay, we're going to increase that FMAP even more to a little bit bigger amount, to like 6% more, so that it'll cover the costs during this pandemic. The second one was the American Rescue Plan, which was signed into law in 2021 by President Biden. And what that did is increase that FMAP even higher, 5% for 2 years. It extended postpartum coverage for 12 months for the states who wanted to take it up, and California certainly did. And then it gave more funds to rural providers who took care disproportionately of Medicaid patients. Now, every good thing comes to an end, and so did COVID. And it went through something called the Great Unwinding. Because in 2022, Congress declared the pandemic would end on March 31, 2023. And as a result, continuous enrollment would end after March 31, 2023. The increased FMAP would end as well, gradually through the year. And by 2024, 25 million, including millions of children, were disenrolled from Medicaid, mostly due to paperwork problems, not because they didn't qualify, because they didn't fill out the paperwork. And of course, it was different in every state. California, 19% were disenrolled. In Texas, more than half of the people on Medicaid lost their Medicaid. Now, let's compare these two states, California and Texas. And the reason why Texas is close to my heart is I lived there for 12 years. So I know a little bit about healthcare in Texas. In fact, that's where I learned this whole thing about Medicaid, is in Texas, taking care of children on Medicaid. So let's look to see the differences for children, pregnant women, adults, and then people getting long-term care through Medicaid. For children 0 to 1 in California, we know what it looks like. In Texas, Medicaid eligibility is very similar, but you see that for CHIP, it only goes up to 206% of the federal population. So you're going to have a lot more children 0 to 1 who are uninsured. 1 to 5 in California. Texas, very similar, but again, CHIP doesn't make up for all those uninsured children like they do in California, like it does in California. And children 6 to 18 in California, as opposed to children 6 to 18 in Texas. As a result of this, there are a lot more children in Texas who are uninsured as opposed to in California. If you're pregnant, that's what it looks like. Pregnant in Texas, Medicaid eligibility, similar, but CHIP is not as generous. So of course, a lot more pregnant women are going to be uninsured and not getting their prenatal care or their birth or postpartum care. Adults, of course, up to 138% of the federal poverty level in California. In Texas is a different story. Texas is one of the states that did not expand Medicaid. So first of all, you must be a parent to qualify for Medicaid, and you cannot make above 15, that's right, 15% of the federal poverty level, or about $6,000 per year in a family of 4, and qualify for Medicaid. So that's why very few adults are covered in non-expansion states. SSI is more generous in California than it is in Texas. And then we talked about long-term care in California. And in Texas, it's a little different. There are income eligibility, and it goes up to 230% of the federal poverty level. And you're allowed to keep $62 per month for your personal needs allowance in Texas. So this is how the two states compare. What I'm trying to say here is, particularly here in the non-expansion states, you have a lot of adults who are uninsured. Now, having said this, 138% of the federal poverty level to qualify for Medicaid is still not a whole lot of money that you're making. However, there are a lot of people on Medicaid. Let's talk a little bit about reimbursement, because I think that this is very important. For every dollar of reimbursement for a patient on Medicare, Medicaid is only reimbursed 72 cents, and private insurance is reimbursed $1.30. So that means that Medicaid is reimbursed almost 30% less than Medicare and almost 60% less than private health insurance. Now, what does this mean? Well, it means that it's a huge disincentive for you as a provider to accept Medicaid patients or to accept a lot of Medicaid patients. Your practice is not going to be doing very well, or you're going to have to be seeing hundreds and hundreds and hundreds of patients, maybe not every day, but certainly every week in order to make up for that revenue. And that means that you're not going to be able to recruit staff or even to retain the staff because of the fact that you're not making very much money. So those are some of the problems with the reimbursement. But I think the worst part is that it sends a message to Medicaid recipients that they are valued less. Total Medicaid spending, a lot of people make a lot about the privatization of Medicare. Medicare is privatized. 54% of Medicare beneficiaries are on Medicare Advantage. In Medicaid, 75% of Medicaid enrollees are privatized in a managed care organization. Now, the total budget is about $880 billion per year. That was 2023 for the total Medicaid spending. And the reason why this is important is it's going to come up in a minute. So remember, $880 billion per year. Now, today, Medicaid covers 63% of nursing home residents. That's where the biggest amount of money in the Medicaid budget goes to nursing homes. Almost 50% of children, 41% of births, 41% of working age adults with disabilities, 18% of Medicare beneficiaries, and 16% of working adults between 19 and 64. And this population is going to become important in a minute. Now, race is very important for us to talk about when we talk about Medicaid. If we look at the population of Medicaid, 36% of the people on Medicaid are white, 24% are Hispanic, 19% are African American Black, 4% are Asian, and 17% are either biracial, others, or unknown. So more whites than Blacks or Hispanics are on Medicaid. But Medicaid, as you will see, is overrepresented in minorities. So only 10% of whites are on Medicaid, whereas 25% of Hispanics and 25% of African Americans are on Medicaid and 11% of Asians. Which means that when you have expansions to Medicaid or cuts to Medicaid, you are really targeting minorities. Minorities are going to be the ones who are going to feel the effects of changes to Medicaid more than anybody else. Let's talk about immigrants. And these are immigrants who were eligible for Medicaid before HR 1, before the big, beautiful bill. Not eligible for Medicaid have always been undocumented immigrants and temporary protected status. I know it's different in California. We're going to get to that in a second. Eligible for Medicaid, lawfully present after 5 years. So green card holders after 5 years are eligible for Medicaid. There is no 5-year waiting period for refugees, asylees, COFA nation people, children in 37 states, pregnant women in 31 states, and CHIP in 24 states. In California, as of 2016, children, regardless of immigration status, have been eligible for Medicaid. And as of 2024, of course, this has changed. As of 2024, in California, all income eligible residents, regardless of immigration status, so undocumented, as long as they met those eligibility criteria, would be eligible or eligible for Medicaid. And emergency Medicaid, of course, covers lawfully present and undocumented immigrants as well. Little aside about emergency Medicaid is when you have an undocumented worker who is a roofer and falls off the roof, and I have seen this in Houston many, many, many times. They fall off a roof, they sever their spinal cord, they do get taken to the emergency room to be taken care of in the hospital. But the minute that they leave the hospital for any rehab, for any medical equipment, for any medications, for wheelchairs, anything like that, Medicaid is not there for them. Now, most undocumented immigrants work, as we're going to see, when compared to US born. about 60% work, whereas 70% of undocumented immigrants work. However, their income is much, much less. So the household income under $40,000 is under 100% of the federal poverty level. You can see that 72% of undocumented immigrants live at or below the poverty level, despite the fact that most of them work. In fact, compared to US born, immigrants use less health care, spend one half to two-thirds less on health care, and subsidize healthcare for the rest of us. So thank you, immigrants. Most adults on Medicaid work. So if we look at Medicaid, we see that 44% of the people on Medicaid work full-time and 20% work part-time. Now, that means that 60% of people on Medicaid are working either full-time or part-time, which means that Medicaid is subsidizing corporations with low-wage workers because those employers are not offering health insurance or they're offering such meager wages that they qualify for Medicaid. Now, about 36% do not work, but let's dive down. 12% of them are caregivers, 10% have an illness or disability, 7% are students, and 8% are retired. So most adults on Medicaid already work. Then came H.R. 1, the one big beautiful bill. What repeal and replace during the first Trump administration never achieved has been achieved through H.R. 1. It is modeled on Project 2025 and with the purpose of reducing health federal spending and expanding the role of the free market in healthcare to repeal or roll back any premium supports such as the exchanges, any coverage mandates, and specifically to target the expansion of Medicaid in the states that took up Medicaid expansion. Specifically targeting Medicare and Medicaid to privatize it and to reduce any kind of federal oversight as much as possible, and specifically to target reproductive rights to severely curtail abortion and even some contraception. Now, what's happening to immigrants after H.R. 1? Well, this is a list of not eligible beneficiaries or people not eligible for Medicaid after H.R. 1. Undocumented immigrants, obviously not. Temporary protected status, still not. But all refugees, asylees, trafficking survivors, survivors of domestic violence, and any holders of valid work or visa holders are not eligible for Medicaid, even if they wait 5 years. In California, there will be no new undocumented immigrants allowed to be eligible for Medicaid if they're over 19 years of age. And for those who retain coverage, meaning that they received their Medicaid before January 1, 2026, their dental coverage will be eliminated and they will be required to pay monthly premiums starting in 2027, I believe. Those who remain eligible for Medicaid are those lawfully permanent residents, green card holders after 5 years, some Cuban, Haitian, and COFA people, children and pregnant women still are eligible for Medicaid or CHIP. In California, children under 19, regardless of immigration status, eligible. In California, only lawfully permanent residents and the undocumented if they signed up before January 1, 2026. And then we have emergency Medicaid to cover lawfully present and undocumented. And just a little word about emergency medicine, and that is that the emergency medicine is paid by the federal government, but it makes up less than 1% of the total Medicaid spending. Now, Medicaid is under fire. Let's talk about the funds that are being cut. It's going to cut $911 billion over 10 years. Remember the Medicaid budget, $880 billion in 1 year? Well, this is going to cut 911 over 10 years, so about $91 billion per year over 10 years. It will eliminate that 5% increase in the FMAP. For any new states that decided they finally want to expand Medicaid, so those 9 holdouts, if they decide now that they want to expand Medicaid, well, forget about that increased FMAP. You're not going to get it. So, huge disincentive for states at this point. And it does change these provider taxes. These are the taxes that health entities in the state have to pay. And this has been a major source of revenue for states to fund their Medicaid programs. And of course, the Trump administration is targeting anything that that states could possibly try to raise to fund their Medicaid program. The law prohibits any new provider taxes. In these non-expansion states, these 9, it freezes taxes at the current rate. And then in all the other states, it begins to decrease these provider taxes by 0.5% every year until it gets down to 3.5%. It will add $10 million, sorry, 10 million people to the uninsured rolls by 2034. So it increases the number of uninsured by 10 million people. And mostly it's targeting expansion states. There will now be a $35 copay on adults, and there will be stricter eligibility verification every 6 months. So in California, it used to be every 12 months. It is now going to be every 6 months that you have to prove that, with your pay stubs, that you haven't gone over the limit, that you still reside in the state of California and so forth. And of course, it's going to impose new mandatory work-related rules on about 15 million enrollees. We know that most people already work. It's going to require 80 hours per month of either work or a work education program or community engagement. And people are going to have to document that they're making at least $580 per month. There will be exemptions if you're medically frail, if you're a caregiver taking care of someone under 14 years of age, if you're in a substance use program, if you're pregnant, postpartum, and so forth. But it will create huge costs for states because states now are going to have to create new systems to report, track, verify this work compliance. And in Georgia, we had a natural experiment. And in the year 2024, to monitor 35,000 enrollees, the state spent $26 million. So it's going to increase that. In summary, Medicaid was created to cover the medical needs of poor people. The funding came from federal and state governments. It gave great power to the states to determine eligibility and benefits. And it was always meant to be means tested, where you had to prove your poverty and to be poorly reimbursed. And I would like to end with a quote from Barbara Commons, who is a HICAP counselor. From my HICAP counseling of people in Medicare and Medicaid, I see its classist, sexist, and racist nature. People on Medicaid have to prove that they are still poor every year, and now it will be every 6 months. The richest country in the world has no business having health care for the poor. We've been waiting 60 years to get this right. Let's demand the gold standard. They have kept us waiting too long. One people, one plan. I couldn't have said this better myself. So let me stop sharing. Happy to answer questions. As we know, we don't necessarily want to save Medicaid, but what we really want to do is to save the people on Medicaid. So happy to, Deborah, go ahead.
Yeah, great. Anna, thank you so much for this really comprehensive look at Medicaid across the United States and then focusing on California and Texas. I learned quite a bit tonight, and I think one thing that struck me as really unfair is the subsidies we're providing to these corporations that employ these people. And I was watching something earlier today about the SNAP program, which does that as well. It's subsidizing corporations that are not paying people enough money to buy food. And they're having to make, decisions about their medical care, their food, their housing. Which bill will they pay first with the very few funds they make? And so I guess one question I have is with these subsidies and with the cuts and the people that are no longer going to be covered, they're uninsured, where will they show up? At the emergency rooms for emergency care? You know?
Well, this is what state legislators, county legislators, city legislators are all talking about. I mean, they're really on fire because they know that their budgets are on the line. And I was just reading this paper from the Organization of Counties in the United States,
Mhm.
and that's they're saying that people are going to get uncompensated care. They're going to go to the emergency room. They're going to go to clinics, to the federally qualified health centers, and they are going to be seen, but there's going to be a lot more uncompensated care.
And
So, what does it mean when you have uncompensated care? Well, either people are turned away. A hospital emergency room can't do that, but a clinic can. You can turn people away if they can't pay, um, and it just will raise costs for everybody else because hospitals are going to have to make it up somewhere. Clinics are going to have to make it up somewhere. So there's always, paying Peter, no, robbing Peter to pay Paul kind of situation in our healthcare system.
mhm. Thank you, Anna. And I guess we've got one hand up with Peter.
I'm a little confused about when we say Medicaid is privatized largely. Does that mean that people go to private providers? Or, I mean, does the government function the role that an insurance company would play? I mean, break that down for me a little bit.
Yeah, no, thank you. I glossed over that because, as I said, was speaking for 40 minutes and I didn't want to bore everybody to
I'm
tears.
at it again. I'm sorry,
No,
Anna.
no, 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 no. That's okay. It's an important
It's a
point.
good
What do
question.
I mean when I say that Medicaid is even more privatized than Medicare?
Yeah.
So, just like with beneficiaries on Medicare that can choose to be on Medicare Advantage or to remain on traditional Medicare, um, Medicaid beneficiaries are not necessarily given the choice, although some states do allow that choice, but they are funneled into a managed care organization. A managed care organization works just like any insurance company that gets a capitation for every person in their plan and then pays the providers accordingly, according to, negotiated contracts that they have set up. So yes, this is federal money that is going to managed care organizations to manage the care of patients on Medicaid, just like it happens in Medicare. I hope that that's clear. I don't see Peter. Oh, there you are. Mhm.
Yeah.
Yeah, I guess what's confusing me is that when you say managed care, you mean an HMO
It's a
or
managed care organization. It can be Blue Cross Blue Shield. It depends on the state. It can be Centene is the big one. It's a huge, huge, huge one. It can be Humana.
Mhm.
Those are the ones that are running these managed care organizations.
But we're not talking about independent practitioners or
No, 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 no,
public
no,
hospitals or anything like that.
no, no. A managed care organization is another word for an insurance company,
Okay.
but it's for Medicaid.
Mhm.
Thank you, Peter. We'll turn to Robert Lehman. Go ahead, Robert.
Yeah, thanks, Anna. Um, can you talk a little bit about the administrative costs, the relative administrative costs of uh, Medicaid, both as for managed care and for the non-managed care part, as compared to Medicare administrative costs, and also how much paperwork time do providers have to spend on Medicaid uh, documentation for the, you know, various programs, if you know?
Actually, I don't. I don't. Um, that's a really good question. I've not thought about it. Um, my guess is that it's probably, well, let me just put it this way. I should say I don't have an exact answer, but the people in Connecticut can probably answer that question for us. Connecticut was one of the states that about 12 years ago decided that they were going to kick out their managed care organizations because of the fact that they were spending so much money on managed care and they were not seeing any improved outcomes. They were seeing higher and higher and higher costs. And so the state of Connecticut decided that they would just kick out all these Medicaid managed care organizations. And as a result, the cost of administering the program went down significantly. The outcomes improved. For example, ER visits went down, chronic illnesses improved. So, what they found is that the program costs them a whole lot less to administer under fee for service than it did under the managed care organizations. I can't give you an exact percentage, but that has been the experience in states such as Connecticut. And there are 5 states, only 5 states in the country who have kicked out their managed care organizations. And I don't know if Barbara is raising her hand to tell us. I don't think Massachusetts
No,
is
no.
one of them.
But I think Minnesota is trying now, and I forget.
And I
Sorry.
think even Washington State is trying to do
Yeah,
that. I mean, it kind of makes sense if you're trying to save money for Medicaid, is honestly, rather than a wealth tax,
right.
um, to kick out all the Medicaid managed care organizations from Medicaid, and you're going to spend a whole lot less money and have much, much better outcomes. Sorry, Barbara, go ahead.
Well, I just was going to tell the person if who asked the question that the PNHP study on Medicaid goes state by state, and it does have something about um, the amount of administration compared across the private and non-private, or how much they could save if they did do the Connecticut thing. But the biggest problem, of course, is that every state, as you have said very clearly, every state's different, and nobody reports, and nobody is keeping track of the managed care organizations. There's practically no supervision whatsoever, and yeah, it's a disgrace. Another disgrace. Hey, surprise. But
It's a black box. You're absolutely right, Barbara. There's no requirements to report. Yeah, yeah.
and so, but anyway, I forget. It's late. I had something
Thank you,
else that I
Barbara.
was going to say, but
But
it is
that's
just
a good
it's
reference. That PNHP.
the PNHP study is quite nice, and Connecticut also had better participation from the physicians as soon as they switched. Was the other thing that they said. But
Exactly.
that wasn't what I meant to say. Anyway, thank you. Thank you for the program. I think I'm going to fade pretty soon.
All right.
Thank you, Barbara.
Thank you for joining us, Barbara. Patty Harvey, you're up next.
That was a fantastic presentation, Anna. It's so detailed, so much I didn't know about and how that all works. Probably won't remember it very well, but the slides are there to refer to. So thank you for that. But I just had a question. I'm wondering, are all managed care, do all managed care programs use some form of capitation?
Yes.
Or did, because,
Yes.
I mean,
That's
it
the
just seems
definition
like,
of managed care.
okay, because it just seems such a logical, obvious thing that using capitation just means there's going to be bloat and denial, and that's going to raise costs and reduce access.
Good point, Patty. Thank you. We've got Hannah up next.
think Sally is before me. Does Sally want
Sally
to?
Roberts?
Oh,
Okay. Briefly, I just wanted to say that West Virginia, I think, has the largest share of Medicaid monies. And so these cuts will really impact our state negatively. We are losing hospitals already and likely to lose even more, which will affect everybody's health care, whether or not you're on Medicaid or the ACA. So these large cuts, and I think everywhere, will affect everyone, no matter what kind of insurance you have. So I just wanted to add that.
Thank you so much. The title of this is A Cut to One is a Cut to Everyone. You're absolutely 100% right. I didn't even really talk about how these cuts are affecting state budgets as far as their hospitals are concerned, but it's really hitting rural states very, very hard. And West Virginia would be one of those states that is losing many, many hospitals. California is on track to lose 24 rural hospitals as a result of HR1. And obviously, one way to save these rural hospitals is to have a national single payer healthcare system. Because if we had single payer, then we would distribute our resources according to need and not according to income. Or according to how much money the particular for-profit or even not-for-profit corporation or academic center wanted to make. So that's a really, really good point, that rural hospitals are at risk of closing due to the cuts, and the only solution is to have a national single-payer healthcare system that would at least redistribute the budget so that these rural hospitals would be able to stay open.
thank you, Anna. And Hannah, thank you for pointing out the other caller who was ahead of you. I only see a few in the queue, and you're up next from what I can see.
Thank you. Yes. Thank you very much, Deborah. And thank you, Anna. I live in California. I have all my life, and I'm an IHSS or Medicaid HCBS home and community-based service home care provider. And so obviously my clients are on Medicaid, or as we call it, Medi-Cal in California. And I myself am on Medicaid, Medi-Cal ever since I think it was around the pandemic when my schedule would fluctuate too much and it was too crazy to stay on the benefit that my union fought very, very hard for me to have, which I really appreciate. And it was good benefits, but and very low cost, but it was cumbersome because you had to be able to claim a certain number of hours every month. And then if you didn't and you get bumped off, it took 3 months to get back on, blah, blah, blah. My real question, I have to say, I am totally overwhelmed by everything you said. What I learned the most is how little I know about this system and how this all works. So it's incredibly complicated. But I do know that single payer is the answer. And I'm very proud of our California legislators who did introduce today CalCare back into the assembly. And I hope that this year they do not back down and take it off the table. But that's what's happened in the past. We've been fighting for this for, I don't know, 30 years or something. So, and of course, California being the fifth largest economy in the world, we believe that if California can pass it, then the country can pass it. And once we get it passed, the country will follow suit and see that it's really valuable. Now, that probably won't happen anytime in the immediate future, but I guess I just wanted to know I'm not exactly sure how I have a question, but it's sort of like, how does CalCare fit into this? If we did get CalCare passed, how great would that be for Medicaid and Medicare recipients? I'm actually on both now. I just turned 65, so I made it onto Medicare as
Congratulations.
well. Thank you.
So, I mean, unfortunately, what these federal cuts show us is how vulnerable states are to the whims of the federal government. And we see very, very clearly what happens when state budgets have to tighten is one of the first things that will be services for the needy, for the vulnerable, and particularly healthcare services. So it just shows you that it's very difficult to rely on state budgets to be able to pay for healthcare. And as everybody here knows, I'm a much bigger proponent of a national single payer healthcare system than a state single payer system for many reasons. But I think that having a system where everybody is in, would be much, much better than what we have right now. But I worry that that our healthcare system is still going to be under the the whims of state budgets. And so when you've got, a healthy year, then you've got a state budget that you can really pay for a lot of things for. But when you have to tighten your belt, you don't have the federal government there to rely on. So, I think, it's great that CalCare has been introduced, and I know that a lot of people on this call are very, very excited about it as well.
Thank you, Anna.
Were you
I
going to stop
certainly
at
would
11?
like to see the whole country benefit from a single payer. That would be my goal. But
Right.
That's
Of
everybody's
course,
goal.
that
That's
is everybody's
everybody's
goal. Yeah. And when we expanded Medicaid, we wanted everybody to expand Medicaid, and we still have 9 states that are holding out.
Were you going to stop at 11 or are you going to keep going?
Oh, go ahead, Barbara. We have time for your question or your comment. Yeah.
Well, I was thinking of states that have that are trying to do a Connecticut, and Hawaii is one of them, which reminds me that Steve Kimball has great reports on. It's not just fee for service that they go back for. There's also sort of fee for service with coordinated care in addition. And that's what Connecticut did, and that's what the states that are going to emulate it are going to do too. Also, this is not all of Medicaid, but I have been, since last summer when I learned about it, many of the Medicaid offices in the red states kicked out their pharmacy benefit managers for Medicaid and went with a single state-run pharmacy benefit manager. And then if you go to the Ohio Medicaid office, for example, they have a little explainer video about why it's so much better to have a single payer. But anyway, and a number of other states did it too. I think maybe West Virginia, but Kentucky and other red states just said, we can't afford this. And it was not just that they couldn't afford it, but that the pharmacy benefit managers or the private people were destroying the pharmacies. They weren't paying the pharmacies. So the pharmacies were getting crushed. And so they had to save their pharmacies by getting rid of the people who were crushing them. Anyway, it's just a little piece of Medicaid, but it's a piece of the puzzle, and it's just such an irony. But I wish
Thank you.
it could spread. I wish it could spread.
Thank you, Barbara. And I think we had one other question from Carol Harvey. Carol, or did you get to ask your question, or do you have another question?
Oh, you on mute.
You're muted, Carol.
Can you hear me now?
Yes.
Okay, I'm not sure this question fits into the subject matter tonight, but I'll ask it anyway. Um, maybe you've covered it in other meetings. In order for the United States to get universal health care, which is far overdue, we will have to make sure that it is not capitalistically based. My belief is that we have to get rid of capitalism to get universal health care. Um, uh, but my question is this. I talk to people in other countries all the time. Canada in particular, several people in Canada have said to me that yes, we have universal health care, but it's really bad. It's a very low quality. I lived in London for a while. That's not true. That I see Barbara Pearson shaking her head. Okay, that's good because I really would like some response to this. I lived in England for a while in the 70s, and the same thing was really true. That the medical care was pretty bad, pretty low quality. But I talked to an English doctor in the countryside, and with great horror, he said, "We heard about your United States doctors. They're all about money," which I don't know if it's true now. I don't find it true. I think doctors are fantastic. I just went through a whole round of visits to hospitals in San Francisco for some unidentified pneumonia, and all the doctors were wonderful. So does anybody have any responses to any of that? No?
Oh, yes, yes. I mean, I think that there's a lot of disinformation, a lot of misinformation out there that is propagated by people who would lose millions and millions and even billions of dollars if we were to kick out the health insurance companies, if we were to make it so that pharmaceuticals would have to negotiate with the federal government. So there's a lot of misinformation, and there's even misinformation coming out from think tanks, particularly the Fraser Center in Canada, that puts out lots and lots of negative information about the Canadian healthcare system. So when you look at studies that compare the Canadian healthcare system and the US healthcare system, the Canadian healthcare system spends almost half of what the US healthcare system per capita spends, and yet their outcomes are either just as good and sometimes even better. So that I would say about Canada. There's this myth about all these people in the northern part of the country flocking to Canada. From Canada flocking to the north of the country to get healthcare, but it's really more Americans that are flocking to Canada to get less expensive prescription drugs. So that's what I would say about Canada. What I would say about the UK system is that every country, their healthcare system is going to be a reflection on how much money they spend on it and the resources that they spend on it. Except for the United States. The United States is an outlier because despite the fact that we outspend every other industrialized country by twice as much, except for Switzerland, we still outspend them, but not by twice as much. Our outcomes are nowhere as good. But there are systems out there that are starved for resources. And as a result, you're going to have poor outcomes. There's just no denying that. If you don't have enough primary care physicians, if you don't have enough specialists, if you don't have enough CT scanners, MRI scanners, if you do not invest in your healthcare system, then of course people are going to have to wait in line and people are going to become unhappy.
Well,
and unfortunately, the NHS has been subject to that, particularly during conservative governments that underfund.
Could I add another comment, Anna? I would like to thank you for going through all this, even despite your issue with talking, I really appreciate your effort here a lot. Thank
Thank
you.
you. Thank you.
Thank you, Carol, and thank you, Anna. And I was going to say, I see no other hands being raised. If I could go to the reminders, which I believe Anna has already posted in the chat, but I would just like to say a few words about Friday and Saturday, February 20th and 21st at the Moscone Center. We will be leafleting for single payer at the California Democratic Convention. If you're available, please come out to help us. Let us know we can get you to the right place at the Moscone Center. And I
What
think
day
it's
is
a
that? Sorry, what day?
February 20th and 21st at the Moscone Center in San Francisco, Friday and Saturday. That's a week away, I believe. And then Wednesday, May 20th, Senior and Disability Action will host their 2026 Spring into Action annual event. It's a fundraiser, and it'll be from 5:30 to 8 p.m. at the First Unitarian Universalist Church and Center of San Francisco. It'll be a beautiful evening with a variety show and time for food and drink. And we just hope you'll come out and show some support to SDA for their last year of effort, as well as helping raise funds for the future. And lastly, we have a survey for you to complete, which may help us develop our topics for the future teach-ins. So if you have a chance, please fill in the survey. And I think that's a wrap, unless there's any other comments, Lihia, that you or Grace want to make, or Anna.
No, I
Been a
just want
great
to thank
evening.
everybody. Thank you.
Yeah.
Thank
Thank
you,
you,
Anna.
Deborah, for
I
hosting
just,
us again,
Yeah.
or facilitating this again. And thank you to Ligia and Grace and everybody at Senior Disability Action. Thank you. Thank you, everybody, for
Thank you
being
so
here.
much.
thank,
Thank you.
Thank you.
Anna, this
Thank
was
you.
fantastic. I learned so much. I'm like, what?